So major disadvantage of CT, let's start out with it. I mean, you need contrast, obviously, so it's not so good if you have renal insufficiency. Radiation, it used to be a big issue. Now I think we have much better tools to minimize that. Regardless, it's something that you want to be careful about and to minimize the amount of dosage that you administer to the patient. In old days, I used to put mostly anatomical information. I think, especially for coronary CTA with the advent of FFRCT, now we can extract a lot of functional information from the coronary standpoint. And with the flow modeling, you can even probably get some, in the future, some functional information from the cardiac function. Advantage, I think, compared to, this advantage I put it here is compared to other non-invasive modality, okay, mainly echo, nuclear, MRI, not compared to invasive. So it's probably it is, thank you, it is the non-invasive technique with the highest spatial resolution, okay? So I'll say about 0.5 millimeter, which is sufficient but not ideal. Ideally, you want to reach to the point that you can do the micro CT, in which the spatial resolution could be micron. I don't know if you all seen some micro CT images. Basically, you can see the nephrons and alveolar. So it's pretty amazing. But I'm sure one day they'll get there. And the second point is very important. It's called isotropic voxel resolution, meaning the spatial resolution in all 3 dimensions are exactly the same. How is that important? It's very important for volume calculation. Okay, so in 3 axes, the resolution is exactly the same, so the image is not distorted. You can manipulate from each angle you like. The image will remain representative of the true dimension and shape of the structure you want to look at. High contrast resolution is relative in a sense that obviously it's probably better than echo and nuclear, but depending on some patients that we image sometimes is not as ideal. The next point is really fast. I think this is no question about it. I mean, it's something truly amazing about CT is you can image the heart in such a short period of time that you don't, oftentimes you don't even need a breath hold anymore. It's very important, especially for inpatient, that sometimes they have a hard time laying flat and holding their breath. And with the newer scanner, the fast acquisition time is very, very powerful. And obviously, different from echo or nuclear, you can obtain images outside the heart, okay? Which for some surgical planning is very useful. And then 3D rendering, I'm going to show you some images. I think that's, again, one of the most powerful display tool the CT has. It's a truly 3D technique. From diagnostic standpoint, sometimes it's useful, but I think it's very useful from procedural standpoint to have the true anatomical representation as how the surgeon see it. But traditionally in our non-invasive imaging training, we're looking at the heart like echo from 2D perspective in different orientation, which has nothing to do with how the surgeon approaches. I think we should probably learn a little bit more and more how we display and read these images, how our referring physician see it, so to improve the communication. And CT offers that tremendous opportunity in terms of you can orient the structure of the body the way you want, exactly the way the surgeon see it, and therefore I think the image of the information obtained will be much more useful for the referring physician. So this is why we do CT. I think the most powerful role of CT, coronary CTA at this stage, is truly to rule out presence of coronary disease. I believe this person somewhere here in this room, okay, I'm showing his heart. I think he was very happy. I think he's had family history of premature coronary disease. dad has MI in his 40s, and so he was very concerned. So we were able to do this study. He had some atypical symptom, and we did this coronary CTA with, I believe, with less than 2 millisievert of radiation, which is less than what you receive from the environment living here in Houston. So very powerful tool. You can see perfectly clean coronary. That's one other advantage of CT is compared to invasive angiogram. You can see beyond the lumen. Besides excluding presence of obstructive disease, you can confidently tell the patient you have atherosclerosis in your coronary or you do not, which is very important prognostic. Okay, this is all, this not, you know, in the left-hand side you can see the plaque. Let me see if I can. This is a patient coming with the ER with chest pain. Young guy, a smoker, a little bit of calcification right here. You can see the white speck, but mostly in the left main, very, very hypoattenuated lesion, very high-risk feature. So he went to the bypass surgery. So, and this is the function. And just give you one example of what the 3D display can help. This is a patient with right heart, presented with right heart failure. You can see an angiogram. There's something wrong with the right coronary. No offense, Deepan is not here. I chose a really bad example of what CMR can do, so it's not fair. I'm playing dirty here. So you can see the image is, I think maybe because the patient wasn't very cooperative, so I don't know exactly what the reason the image wasn't great. So there was suspicion of, obviously, some congenital anomaly, probably arteriovenous malformation, fistula, very large RCA. So, you know, MRI kind of confirmed that a little bit, but without this anatomical detail the CT could offer. As you can see here, very large RV, very large RA, gigantic coronary sinus, and you can see this snake-like structure, which is the RCA. But I think the most important part is the next picture that I was going to show you, is with this 3D display, you can pinpoint exactly where the right coronary artery communicate or drain into the coronary sinus, and it's, I'm sorry, right here, and its relation with the descending aorta. So it's very useful for the surgeon in terms of going in there, know exactly where to go, and ligate this structure. Okay. So before I go to this advantage, I want to show you what 3D display, because you all heard about 4D CT, and now everybody, all the valve service want to send the patient here. We want 4D CT. And it sounds like something was invented in 2015 and something brand new. As a matter of fact, you know, radiologists, academic radiology, I should say, have been doing that for probably 2 or 3 decades. So all you do is you have a 3D display, you obtain different part of cardiac cycle, and you play it. And that make a time resolve 3D display. Okay, that's called 4D CT. So I'll give you some example. I apologize, I haven't opened this file. So this is the patient with mitral valve prolapse. Okay, so this is a display. I mean, if you look at this, Mohammed, do you think this is 2D or 3D? It's kind of blur, right? The line is blur, right? It looks like 2D, but you see some depth, right? So yeah, it's kind of like what we do 3D echo, but zoom in 3D echo. So you're getting a slice of the heart. I mean, technically it's 3D, right? I mean, but for practical purpose, let's say you cannot see through the depth and you think this is just 2D. So this is a 2D in motion, right? Different part of cardiac cycle. The display looks a little bit funny, okay, because instead of highlighting the contrast, it's highlighting the structure with low attenuation. You know, the valve is very thin, right? So if you highlight the contrast, okay, the pixels with low attenuations going to disappear in your display. So you're not going to see the valve very well here. So we invert I don't want to see sequence because invert the concept. So you highlighting the structure with low attenuation factor or unit. So you can see that the valve very well, the mitral valve very well, but I think this is rare, but one of the best example we have that you can even see the chordae. Okay, so I think, well, someone is nodding their head because I think I gave her this picture. So, and this is important because for mitral valve assessment, you know, the limitation we have with the echo is, or the TE especially, you know, the subvalvular apparatus is in the far field. Okay, so it's oftentimes very hard to get good images, even from transgastric. You know, images still suboptimal, and you can see very nicely all the pub muscles, and so this is, let's say this is 2D. So 3D would be technically looks like this. Let me see. Okay. So this display is very familiar to you all do TE. It's very similar to the AMFAS view from the left atrium looking down the mitral valve. Okay? And this is aortic valve, so this is anterior. So this is 4D CT. So it's a 3D display with time resolved for the 3D display. Okay? And it suffers a similar problem with 3D TE, depending on image quality and the noise. Sometimes, you know, it could look like hole here in the leaflet. That's because during the post-processing, you lose the signal. So sometimes you have to adjust it before you call this a perforation. Okay, so I'll show you one more example of this same individual. Okay, so similar display that I show you, we call it 2D. So this is 3D again, in motion. So this is 4D CT, I should say. Okay. And let me show you one more example of. So, Bashar, what are you looking at here? What structure is this? Come on, you done CT? No, no prosthetic here. Yeah, so this is the aortic valve, okay? And you can see very nicely this 3D or 4D display of the one patient with bicuspid aortic valve. Okay. And then, let me see. Okay. And this is what all the valve surgeons want to see is what we call, so this is still images of 3D patient with prosthetic valve with prosthetic valve thrombosis, okay, of the aortic valve. And this is what they want, what the valve surgeons want, 4D CT. Not every patient we can get image like this, but with good contrast and image sequence, I think we can obtain image similar to this. Okay, so those are, I would say, major advantage of CT in terms of its excellent spatial resolution, ability to display the structure and interest in 3D and even 4D fashion. And all this image could be obtained, for instance, you know, in the worst cases, less than half a minute. Can go from 30 seconds, the longest, with the most detailed retrospective gating from the neck to the groin, to the newest scanner that we have, the flash mode. You can image the whole chest, abdomen, and pelvis in less than 2 seconds. Okay. All right. So not every patient every study we do are so beautiful, all right? So let's get to the dirty and ugly one. So with the new scanner, I think our new fellows are lucky. They're learning the CT but with the older fellow, let's say Josh, who has been here for a while, I think it's not uncommon, unfortunately, to see image like this with our scanner. Okay, so we suffer a lot of problems. First, this could be oftentimes be avoided. Patient's motion. Okay, patient's motion is relatively easy to detect. You can see the break line in the sternum or on the spine. Okay, and this is most of the time to do shallow breathing. You can see, patient wasn't educated or instructed well before the scan. So that could be avoided. Temporal resolution. Okay, this is the worst part of CT is we're not as fast as other imaging technique in freezing the heart. Okay, so this is very important. That's why we still have to give beta blocker because slower the heart rate, less motion we have. Okay, and this is just an example of how this works. And people have to take the pain of measuring the movement of the coronary segment by segments in different part of cardiac cycle. As you can see, the velocity of the coronary change during the cardiac cycle. When you went to the cath lab, you can see, how much RCA go up and down and go side to side, swing back and forth. And so in that motion, require a device who have enough shutter speed in their camera to freeze that RCA, segment of RCA for us to be able to analyze adequately. And this is a perfect example. So not all the segments move at the same time. As you can see in this example, the mid RCA usually, close to the crux, that's where the move the most and suffer the most of the motion. Okay, so this is another example, just different cardiac cycle. The RCA go from pretty much uninterpretable to perfectly interpretable. Okay, and people have studied that, the effective heart rate to diagnostic accuracy of CT that's been fairly well established. The higher the heart rate, lower your accuracy. So, okay, this is quite rare, but oftentimes you can see, sometimes you can see this type of a problem. The patient with very prominent T wave and the machine doesn't know. Thing is just like Gemini really fast, and you get a picture like this. So, and the good thing is once you acquire the data, you can go back in and post-process. During post-processing, you can eliminate all the data set from the T wave. You reconstruct the images, as you can see here, and give you diagnostic study. So the key is when you see a bad study, you have to do a little bit of forensic work, going backward, different steps to see where the problem resides and try to fix it. Oftentimes you can fix it, and almost all this new scanner can do this. You have a PVC. It could create a step artifact because the PVC is you're imaging different part of cardiac cycle. When you stitch them together, you're going to have step artifact. Okay, calcification is probably I can skip this. You guys seen this before. Okay, atrial fibrillation used to be a contraindication for coronary imaging. It's no longer, I think, let's put it this way. There's still cases it's probably not appropriate to do coronary imaging with AFib. But if it's someone with AFib, unless the heart rate is over 120, 130, very, very irregular, most of the time with our new scanner, we can get diagnostic study. Might not have exactly the same diagnostic accuracy in someone with perfectly normal sinus rhythm. And the reason being that instead of constructing in fixed interval cardiac cycle, which is obviously a bad strategy for someone who is irregular, okay? You can reconstruct the images right at the R wave, or which would be about the end of diastole or beginning of systole, or you can reconstruct the images 300 milliseconds after the R wave, which will be roughly, in most of the patient, end of systole. You know the heart rate variability mostly affects the diastole, okay? Systole is fairly constant, around 250 to 350 milliseconds. So you can see in the left-hand side where a patient with AFib study was reconstructed at 60, 70% of cardiac R interval. In the right-hand side, in the 300 milliseconds after the R wave, okay? So if you have a patient with low heart rate and the diastole is probably reasonable. Patient with high heart rate and the systole, you have better chance of getting a diagnostic testing. And with our new scanner, the temporal resolution is much better, and it allows you to extend or narrow the window that you want to image. So if someone is very irregular, you can open up the window, meaning you can acquire the images in longer duration of time, get more sets of images for you to analyze the coronary. Versus someone whose heart rate is more regular, you can narrow it. And the difference is obviously the amount of radiation you will get. But I would say most of the patients with AFib right now, we can look at the coronary quite well. This is just another example. 65% traditionally, patient with normal sinus rhythm would be good. In these patients with AFib, a 40% image, which corresponds roughly to the end of that systole, is much better. Or you can do absolute time, works as well. So pay a lot of attention to patient rhythm before you image the patient, because that would affect the protocol you will use in scanning the patient. And that's the main difference between us and radiology. Radiology practice is highly protocolized, meaning that till the tech, okay, if you have this clinical scenario, that's what you do. And we work with techs who are radiology tech in West Houston and Willowbrook. I mean, that's what they do. So but here we are different because we try to customize patient's clinical situation with the protocol we use. It's more complicated, but I think it serves better the patient's interest. Okay, I'm going to talk about calcium in presence of coronary calcium in evaluation of coronary artery stenosis. Okay, so patient with minimal calcium this is probably the easiest one, and we usually don't have problem diagnosing study like this. Okay, it's when you have this, that's an issue, and we get referral like this. And there's some cardiology practice this institution. Quite often send us a patient after the cath and then say, okay, can you look at the left main? And if you have 3-vessel disease, left main, and you're going to have a lot of calcium, so CT is not the best way. I mean, you can try. Sometimes we can get good images, but when you get these images, it's very hard for you to interpret it, study. So, for instance, there's a big chunk of calcium there. Is it 100% occluded? Probably not, because you see the rest of the vessel. So just tell you. And this is with older scanner, but with the new scanner, things getting a little bit better, but still it's represent a challenge. This is a study with 64-slice scanner. You can see within the blue circles a lot of calcium. In the white circle, there's not much calcium, but it looks like there's some motion. Okay, so the patient has coronary disease. The question here is how bad the stenosis is. Okay, so you can see the cath here. I mean, actually, within the blue circle, looks like everything is blocked out with the calcium. You look at the angiogram, there's probably moderate stenosis. But if you look at the segment within the white circle, there's not much calcium. You can see it's actually stenosis is worse. Okay, so presence of calcium, even if it's very dense, doesn't mean that you're going to have stenosis, because most of the time it's eccentric, or when it's very severe, it can become concentric, and that pretty much exclude the possibility of seeing through the lumen because of the blooming artifact. Okay, this is another example of a patient with RCA disease. You can see that, the first segment, the proximal segment, is probably okay. The second segment, you have calcium and calcific plaque, and now calcific plaque as well. And more distally, mostly it's just calcific plaque. So this is a mixed plaque, and mostly this is calcific plaque. So this is probably has high-grade stenosis. Here is probably okay, but here, I have to hedge. So this is what the angiogram looks like, and kind of what you expected, that the mid-distal segment has high-grade stenosis, but the more distal segments here has a most moderate. Okay. So how do you rearrange calcium? We used to do non-contrast scan before contrast scan. I think because of radiation concern, we stopped doing that. But now with the new scanner, the non-contrast scan just basically so little radiation. It's amount of, I think, 3 months of radiation from the background. But it's very useful because if you see calcium in a non-contrast scan, and you look at the coronary, the scan with contrast, it helps you to determine if the stenosis is most likely present or not. Because oftentimes you can't tell there's calcium or not unless the calcific plaque is really big. Because if you have contrast in the lumen, which has high attenuation factor, and you have calcium in the wall, and it's not very extensive, you could miss the calcium. Okay, and you have a lot of post-processing algorithm technique. I'm not going to elaborate here, but we go through this when you do the reading. You reconstruct the sharp kernel, increase the width of contrast window, any tricks that you can have in your disposal to try to get rid of that calcium. So, as I mentioned earlier, a lot of calcium are eccentric. Okay, so you can actually rotate it out. You can rotate the vessel. You can look at it from different perspective. So it's like when you do the coronary angiogram in the cath lab, you look at it from different view. Okay, here the difference from the cath lab, here you have infinite view that you can have. Okay, you can go 360 view for each angle. Each degree you can have a different view. Okay, so that's the another advantage of CT. Once you acquire the images, since the true 3D acquisition, you can display any angle you want. Okay, so this is one possibility. Virtual IVAS, I don't think is that useful. But the most important part is if you have a very slow heart rate, the calcium blooming is less magnified. So if you have a patient with fast heart rate, the coronary is moving and has a lot of calcium, the artifact is going to be magnified. So that goes down the principle of imaging. Slower the heart rate, better the images. And different kernel, basically eliminate the noise. You can see through a lumen, as this example, on the left-hand side with the regular kernel. This is type of filter you use. And then in the middle, you use sharp kernel. In the right-hand side, you change the window setting. You can see that it allows you to assess the middle center of the vessel better than just regular display. When you rotate with Dr. Mamarian, you'll hear about him calling the back there, Jeanette, give me the sharp kernel. Right? Anyway, stent is the similar issues. It's probably worse because sometimes the stent is very dense. It's all around the vessel. So it's not only one side. So again, sharp kernel helps. Obviously, larger the stent, better the chance to evaluate instant risk stenosis. Still, stent evaluation is not considered appropriate use. I know we do that all the time. If you have a stent size more than 3 millimeter, it's reasonable to get a CT because the resolution is reasonable if you can have nice heart rate. But if you have a smaller stent, I don't think it's a good use of a technology. Okay? And the rule of thumb is different from cath lab invasive angiogram. If you see the lumen in a segment with calcium, most likely it's not severe stenosis because of the blooming artifact. You always underestimate the amount of lumen that you see. Okay, you overestimate degree of stenosis. You know, kind of different from the cath lab, right? Cath lab, they want you to look at the view with the narrowest lesion. Okay. This, we need to post it in our reading room because this is very interesting study. So this is a analysis of, I think, 5,000 or 7,000 coronary angiogram, invasive angiogram. And all these patients, after the angiogram, they all got a calcium score. So very large number of patients. So depending on your age and your calcium score and gender, you have a very nice pretest likelihood of finding a coronary stenosis more than 50%. So very useful. Okay. This is the most important question because you might heard about this statement or comments that some place, especially in Canada, some people would not do a coronary CTA if the calcium score is too high. Because of the reason that I told you, that if you have a lot of calcium, the diagnostic accuracy is not as good. But I'll just give you an example. You know, for instance, this is a patient with occluded LAD, okay? You can see that where the arrow point out. All of a sudden, the LAD, the contrast stopped, and you have a segment with just no contrast whatsoever. And RCA has also disease, okay? I'm sorry. So, for instance, you look at the RCA in the right-hand side. I mean, this is a patient with very bad image quality. So even if you do a calcium score in this patient, it's going to be very high. But for diagnostic purposes, even if you can make an accurate assessment of stenosis in all three coronary in each segment, for your management purposes, as long as you see a vessel with significant stenosis and patient with symptom, basically that's what the role of CT. I mean, you help you make the diagnosis of coronary disease, patient has symptom, and you're concerned about more extensive disease, they need to go to angiogram, coronary angiogram. We're not going to make a decision on, okay, PCI versus CABG on CTA alone. That day may come when we have enough technology, is just not there yet. So I don't, for clinical research, in a research setting, if you miss, let's say, 5 segments of RCA and circumflex and OM, the study looks bad. 5 out of 17 segments, that's like what, 30%? So if you misclassify 30% of your segment, your diagnostic accuracy looks really bad. But in your clinical practice, if you see a LAD, mid-LAD 90% lesion, you cannot interpret OM and RCA, well, I mean, I don't think it matters too much. You take them patient to the cath lab, you do the angiogram, and if you have 3-vessel disease, then you bypass, depending if they have diabetes or not. Otherwise, you do the PCI. So that's the key. All right. So that's not good. That's not important. Okay. So next, for the last couple of minutes, for those who went through our lab, I know everybody report the coronary lesion a little bit differently. Okay, some people, some of us would measure the lumen diameter and measure the vessel diameter and tell you, okay, this is 30%, 40%, 50%, okay? But we need to know when we give the number, is it really accurate and representative of true coronary lesion? So this study has been a while, almost over 10 years. It's probably the seminal study using 64-slide CT, which is pretty reasonable. And this is one of those best centers in the country. So they compare the QCA of a coronary CTA versus QCA of invasive angiogram, okay? You can see that in the figure A, the correlation is very good, right? I mean, well, we don't have Bob here anymore, so you know, the R is what? 6, and P is highly significant. So, you know, overall as a group has excellent correlation. If you look at B, I mean, you can see the difference in percentage stenosis difference range from one standard deviation range from, I'm sorry, 2 standard deviation range from around 27% each way. Okay, so that means that if you call a best of 50%, 2 standard deviation 90% of the time, you could go from 23% to 77%. Okay, so we need to know our limitation. You can measure all you want. You can call 35, 33% if you want. Or same thing with the vessel diameter. You can call a vessel 2.5 millimeter, 2.3 millimeter, but that's not truly, we cannot be that confident in calling with that amount of precision. So basically, in SCCT, which is our main society for cardiac CT, recognize that. So you mostly quantitative stenosis grading, which personally I don't like, but I use it, especially in cases that I'm not so confident because of the image quality. I think semi-quantitative is a little bit better. You give a range, okay? Essentially, if you say mile, so you're very confident, it's probably less than 50%. So basically, probably we call it, will be invasive, invasive angiogram will be something like non-obstructive, right? But when you have moderate, that means you're really not sure, okay? I mean, it could be 50%, it could be 30%, it could be 70%. And those patients, the cases that you're going to have discrepancy with the functional testing, obviously. Same problem with the invasive angiogram. And I think severe cases when you're really confident that, you know, the lesion is, and when you cath this patient, probably most likely to be 70 to 99%. But we call it occluded, okay? That's another caveat of CT. Remember, when we image the heart, we're only taking a snapshot of the coronary artery, okay? And we're doing it in arterial phase. So if you have a segment which you don't, especially if it's short, which you don't see any contrast, but then afterward, you know, the vessel appears again, CT is not that good in saying this is occluded, total occlusion or subtotal occlusion, okay? That's why with the newer scanner, which allow us to image the coronary in different time frame, will be very useful in determining if, you know, a lesion is total or subtotal, because, correct me if I'm wrong, there's some therapeutic implication, right? If it's subtotal, it will be very easy to fix, stent in, but if it's total occlusion, might be a little bit different. Okay. Okay, big patient, we see that basically, if you have a very obese patient, you need to give more radiation. That's really the only way to get pictures, or you can send them to MRI. So timing is very important. That's coming back to what I talked to you guys earlier about knowing the indication of the study. For instance, on the right-hand side, this is a patient with Epstein anomaly. If you don't know the history and you don't know what they're looking for, and you just image the patient and you want to look for all the contrast will be the left side, I mean, you're not going to see anything in the right, right? So if someone want to look at right heart structure, especially Dr. Lin's patient, I mean, you better talk to him before you tell your tech. I think personally, all you guys rotate through CT lab, unless the indication is abnormal stress test, TAVR. Any other indication which sounds not so clear, I would suggest that you pick up the phone and talk to the referring doctor. That will save you the trouble and save the patient the need maybe for other study. Okay. Timing, okay, that's not important. Okay. So basically, if you're in the CT lab, always try to control the heart rate unless there's any contraindication. Don't let the tech or nurse pressure you, okay? Try to give, if you can, beta blocker, unless we know we don't give beta blocker in patient with AS, okay, or patient in LVAD. Those patients, you don't want to give any more beta blocker, but otherwise try to slow the heart rate. And find out the indication of the study so you can give them the protocol and provide the answer. And obviously, patient who is clearly, you don't think you're going to get a study, don't even bother, because there's other way of getting the information you need.